starting off with some of the strategic policy considerations, learning about the science that's driving it. We did want to put together one other foundational kind of presentation on understanding the epidemiology, the state of things in the province, and I don't think there's anyone better to do that than Dr. Mark Gilbert, who's a community medicine specialist at the BC Centre for Disease Control, has an interest and more than interest, I would say, expertise in HIV and STI testing, internet-based approaches to sexual health promotion, and also gay men's health. In my time knowing Mark, I'd say he's a very thorough, thoughtful, compassionate, patient individual, and I'm pleased that he was able to come here today.
Yes, okay. Great. Okay, good morning, everyone. So if Michelle's caveat was that her presentation had no data, my caveat is my presentation has very little but data. So bear with me for the next 25 minutes or so. But it's sort of an ambitious topic to understand the HIV and AIDS epidemic. So really the learning objectives, I'll spend about half the presentation describing the trends from our provincial surveillance data, talking about historical trends, comparison to Canada, and the current landscape of HIV in BC. But I was also asked to cover some of the factors that influence the epidemiologic trends, and so I'll be outlining sort of a framework or approach that I use when thinking about the trends. So first, the Public Health Agency of Canada does provide us with some estimates of the incidence of HIV in British Columbia. And so there's a couple of points. So first, what we can see here is that clearly that in the history of the HIV epidemic, there's been two major waves of HIV incidence. The first being in the early mid-80s, the wave of HIV amongst gay and bisexual and other men who have sex with men in the province, and then in the mid-90s amongst people who use injection drugs. What we can see encouragingly, and this is consistent with the diagnosis data, is that we have seen a recent decline in estimates of incidence in the province of British Columbia. And in 2011, it was estimated there were 360 new HIV infections in the province. The Public Health Agency also gives us estimates of prevalence, so the number of people living with HIV in BC, and so that is a statistic that continues to increase as new infections occur. And in 2011, it was estimated there were 11,700 people living with HIV in the province. When we do a comparison between BC and Canada on incidence and prevalence based on data provided by the Public Health Agency of Canada, we can see that historically BC has had a higher incidence compared to the rest of Canada, but recently the BC incidence has decreased below the Canadian incidence. And similarly for prevalence, BC has had a higher prevalence of HIV, but what is also striking over time is that the gap is narrowing, so that the rate of increase of prevalence in BC is slower than the rate of increase overall in Canada. So those are very encouraging trends. I'm not going to spend a lot of time talking about AIDS in the presentation because currently right now what we know about AIDS is it's really an indicator of either late testing or poor control of treatment. So AIDS as sort of a clinical syndrome doesn't really exist in the way that it used to. But clearly what we can see is that AIDS has dramatically decreased, and that's primarily due to heart and treatment. So the rest of the presentation on trends, I'm going to be focusing on new diagnosis data. And this is sort of the bread and butter of provincial surveillance. And it's important to know a few things. So this is individuals who've received a new HIV diagnosis, so it excludes people who have a previous positive result, either inside or outside of BC. It isn't a representative of true incidence. It's kind of our best marker, but it is a crude proxy, because we know that diagnosis can be made years after infection occurs, and it doesn't include undiagnosed infections. It's based on data that's elicited by public health nurses or testing providers from the person with a new diagnosis. And it's important to note, as Julio mentioned, that it is heavily influenced by testing behavior. So Julio showed this earlier, so I won't belabor other than say that we are now below the Canadian rate of new HIV diagnoses with 248 in 2012. When we look at the rate of new diagnoses by health authority, we can see a couple of things. So the highest rate in the provinces being in Vancouver Coastal, followed by Northern Health. Encouragingly, in all health authorities, we are seeing a decline over time. And as Julio mentioned before, this is despite the upward pressure of increased testing, particularly in Vancouver and Northern Health. When we look at this by gender, we can see that there clearly is a difference, with the rate being higher amongst males with an estimate, with 217 new positive diagnoses in 2012, and lower amongst females with 31 cases. However, and we do see a decline in both groups over time. With age distribution, it's a fairly consistent age distribution that we see over time, and this is just from 2012, where we can see that typically the average age is in the 30s for both males and females. In 2012, it was highest amongst males, 25 to 29, in females, 30 to 39. While I haven't shown this on the graph, it's encouraging. Over the last 11 years, there have been 2 infant cases of HIV, which has dramatically decreased and really speaks to the success of antenatal heart in preventing mother-to-child transmission. To look at ethnicity, I've sort of broken this out into 2 parts for clarity. So first, looking at new HIV diagnoses who self-identify. It's based on self-identification as Caucasian. So we can see 2 things. First, looking at males on the right, that the majority of cases are amongst men who identify as Caucasian. And it's the most common, but not as common for females. We do see that the proportion is decreasing a little bit over time, suggesting an increasing proportion of people from ethnic minorities or people of color. So then, focusing in a little bit more detail then, when we look at other self-identified ethnicities, we can see, as Michelle acknowledged, that Aboriginal people are disproportionately represented, particularly for women, consistently being between 30 to 40% of all new HIV diagnoses in the province. For males, around 10%. For females, the sort of second most common on this slide would be women who identify as Black, and amongst men, it's men who identify as Asian. In most of the cases that are identified as Aboriginal also self-identify as First Nations, and in collaboration with the First Nations Health Authority, we've done some further analyses of the First Nations data, and what we can see, this is showing the rate of new diagnoses amongst First Nations people in British Columbia, and I think there's 2 things to note, well, a couple things. First, it is declining, so even though the proportion of new diagnoses every year is disproportionate and fairly constant, the overall number is decreasing, consistent with the provincial trend. So that's encouraging. We also see that the rates for males and females are very similar, which is different than the overall province. But we can also see, I'm not showing them on the same slide, but the rate is much higher than the overall provincial rate for both males and females. Something else that we can learn from our surveillance data is stage of infection at diagnosis. So in particular, we look at 2 phases, acute infection and advanced disease at diagnosis. So the importance of both of these are periods, they're important for similar but different reasons. So for acute infection, it's very early. It's the first few months after someone is infected with HIV, when viral loads are very high and the risk of transmission to others is also very high. So increasing our capacity to detect people in the acute phase can have significant impacts on prevention. For advanced HIV disease at diagnosis, these are clearly people who have had undiagnosed infection for a long time, and so that represents, and that could be related to many different factors. When we look in our surveillance data, the blue line shows the percentage of new diagnoses diagnosed with acute HIV infection, so very early in infection, data which we have since 2006, and we can see that in 2011 it was about 10%, and the increase over the past 2 years has been a result of introducing pooled NAT testing at clinics in Vancouver. What we see in red then is the proportion of new diagnoses with advanced HIV disease at diagnosis, and we base that on having an AIDS case report within a year of diagnosis. It's a pretty crude measure, and using CD4 count at diagnosis is much better, and you'll see tomorrow with the presentation from VCH how that's been done in VCH and the success that that's had. But at least by this crude measure, we can see that still a fairly significant proportion of new diagnoses are occurring amongst people with advanced disease. And we do see that when we look at this by region, that there is some variation in this by region as well. We can also look, we know that consistently every year about 60% of all new HIV diagnoses have a documented previous negative HIV test that we can find. Either it's elicited during follow-up or there's a record in the laboratory database. And so that's certainly a statistic we want to improve. But when we do look at those people who have a previous negative HIV test on file, what this graph shows is the time between the last negative test and the first positive test, going back for the last 10 years. So you can see that while it's very encouraging that on the left side, most of the people are clustered over to the left, which means that it's a shorter interval between the last negative and first positive test. So these are probably people who may be engaged in testing, and we certainly can still work at increased frequency of testing. But you do see a disturbingly long right tail, so that within the limitations of this data, we know there's people who have a very long interval between the last negative and first positive. And so that really speaks again to some of the importance of increasing uptake and frequency of testing. Looking now by exposure group, if we go back to the Public Health Agency of Canada estimates of incidence in 2011, this is the distribution in 2011 that's estimated amongst different exposure groups for British Columbia. So I think the data kind of speaks for itself, but in blue are the proportion that are men who have sex with men, including men who have sex with men who are IDUs, so they account for the majority of new HIV infections at 57%, and people living with HIV at 46%, followed by people using injection drugs, accounting for 31% of all prevalent infections, 16% of new infections in 2011, and heterosexual people being the third main category at about a quarter, or 20% or a quarter for both incident and prevalent infections in 2011. So going back to our diagnosis data, what do we know about trends by exposure group? And so I think there's a couple of really striking findings. So first, as sort of was pointed out earlier, as shown in the purple slide, or the purple line in the middle, we've seen a fairly dramatic decline in the number of new HIV diagnoses amongst people who use injection drugs since 2008. The line in the middle, the blue line, is individuals where HIV has been acquired through heterosexual contact, and at the top, it's men who have sex with men. So amongst the heterosexual, and particularly for the men who have sex with men exposure groups, we haven't seen a similar decline in new HIV diagnoses, where the number remains to be stable and elevated, particularly for MSM. And I'm quite interested to see what will happen in 2012. Hopefully these numbers will have decreased. We'll know that in a few months. It's important when thinking about exposure group, that's just at a provincial level, but we also have to think about what's the distribution of HIV amongst different populations at a regional level. And certainly based on the surveillance data, I won't go into this in detail, you can find your own region, we do see a very different distribution in different regions. Again, it's important to remember that this is influenced by testing patterns, so obviously perhaps it's possible that some of the lower proportions in your region may also reflect untested or undiagnosed infections in that population. Just to focus a little bit on the heterosexual contact group, we can see that the rate, the number, which presumably would be the rate as well, is higher amongst males than females. What we do also see is that on follow-up, when there's sort of a determination of characteristics of the individual, we see that about 60% of the new diagnoses fairly consistently in this population have an identified risk factor, shown in green. And that means either they know that they have a partner who's HIV positive, or they have a partner who is at higher risk of infection themselves, such as being from an endemic country or having a history of using injection drugs. So sometimes in this population, this may represent people who are bridging. So it's sort of transmission from a more higher incidence, higher prevalence population into sort of a general population. So that's sort of a whirlwind review of the provincial trends. And so the second part of the presentation is going to be talking about what are the influences on these trends. So, we often say that surveillance data is just the tip of the iceberg, and there's so many factors underneath that really interact and drive, sometimes influencing upwards, sometimes influencing downward on these trends. So as an example, when we talked about the decrease of new diagnoses amongst people who use injection drugs, when we sort of reviewed this collectively as a province a couple years ago for Perry Kendall and the PHO's report, we determined that the strongest influences were from treatment, as Julia shown earlier, as well as changes in drug use behavior and harm reduction practices, all influencing together to see that decline amongst other factors. So to sort of examine this, I can't do all the populations, all the regions justice, because it is very different. And so what I'm going to be focusing on are gay, bisexual, and other men who have sex with men. We're currently working on a report for the Provincial Health Officer's Office looking at this. And also as the population obviously with the most number of infections and prevalence, it's important to be looking at this. So certainly no surprise to anyone that gay and bisexual and other men who have sex with men have sort of been involved with the HIV epidemic right from the very beginning. When thinking about factors that influence trends, I usually think about factors that influence it at 3 levels. And this is sort of adapted from Communicability's epidemiologic framework that often people use when they're describing infections of sexually transmitted infections. And so really at the first level, I think about factors that directly influence whether infection happens. And that's sort of the immediate factors that we often think about. And that includes whether someone who's HIV positive, if they have viral, obviously if their viral load is high, or if they're on HAART and they have unsuppressed viral load, being a factor that directly influences whether transmission happens from a positive person to a negative person. Behavior related to unprotected sex, as well as different kinds of sex having different per act risks of transmission, as well as sharing syringes or other drug-using equipment as behavioral factors. There's also measures of networks, so depending on how many partners that you have or how densely connected your networks are, either sexually or for sharing our substance drug use sharing networks. And then also HIV prevalence. So obviously if you're in a higher prevalence population, you're much more likely to have a partner or be exposed to HIV. And finally, co-infections. So we know that there are co-infections like STIs that can influence viral load and result, or in other ways increase risk of HIV. So that's not a comprehensive list, but it's just some examples of things at that level. So using gay, bisexual, and other men who have sex with men as an example. So we know that there are inherent differences, and these are part of the reason why HIV is so entrenched amongst this population. So we know that anal sex has up to 18 times greater risk of transmission compared to vaginal sex. That's also greater for the receptive versus the insertive position. It's pretty obvious, but unlike heterosexual populations, many men do use both positions. So you're not just restricted to being insertive or receptive, and that has a different factor in terms of mixing that also contributes to the spread. We also know that gay and bisexual men have more densely connected sexual networks, and so there's good evidence that HIV does spread faster just because of the network structure, based on looking at some molecular studies related to number of partners, as well as not just number of partners, but also concurrent and overlapping relationships as being a critical factor to spread. And it's quite striking. This is a theoretical model that was published last summer in The Lancet that really looked at developing a mathematical model that simulated sort of a current population of gay and bisexual men in the province, and then looked at what would happen, and that was sort of based on our understanding of well, simulating as well as we can what we know now, but then also just artificially changing those parameters. So for example, on the left, showing that if you just change the risk of transmission by that 18 times factor to make it the same as for vaginal sex, you'd have an 80% reduction in incidence over the next 5 years if nothing else changed. Similarly, if you artificially said that men can only be insertive or receptive, and so there was no mixing allowed, you'd see upwards of 40 to 50% reduction in incidence over time. So again, I think it was really striking to a lot of us who work in this area, just as a reminder of that there are some inherent features that are acting at this level. Thinking about behavior, we often think about condoms, and I think it's encouraging to note that the majority of men do use condoms almost every time or all the time, and this is fairly consistent over time in BC surveys of gay and bisexual men. So it's really a minority of men who are not using condoms consistently. So again, it's thinking carefully about not thinking about all MSM are the same in that regard. And data from the Center for Excellence for the PHO report has demonstrated that we have seen a decline in the population viral load amongst gay and bisexual men over time, which is really encouraging. And so that really suggests that if we hadn't had such good care and uptake of care, that we'd be seeing more diagnoses than we have to date. And certainly some further analysis with the Center for Excellence, as well as with Vancouver Coastal, looking at some of their data, has suggested there's definitely some groups of men, particularly younger men and men of color, who may be less engaged in treatment and care. And in terms of co-infections, so we know that STIs can increase acquisition, so as well as transmission of HIV. And while we don't have great data on many of the infections for gay and bisexual men in BC because of a lack of sexual orientation data, we do know, particularly when we look at STI clinics, that we see a fairly steady but elevated prevalence of STIs, including chlamydia and gonorrhea, over time. And we do see highly variable and quite high rates of infectious syphilis amongst gay and bisexual men who have sex with men, and that has in 2012 increased even further. So that is definitely concerning. The majority of those cases are amongst HIV-positive men, and so that also suggests that there's sexual transmission amongst networks of HIV-positive men. So moving out from that immediate level, I then moved to sort of a more factors that operate at sort of within relationships or within communities at sort of a community level. Thinking about things like knowledge, attitudes, cultural norms, mental health, substance use, and then factors such as violence, coercion, or power, and also pleasure and intimacy. These are all factors that operate at this level that have an influence on HIV. And what I'm presenting today has all been well documented in the literature in terms of the association between these factors and either unprotected sex or HIV incidence. So one of the things that I think many of us have been struck by when looking at the surveillance data is that we do know that there's some clear generational differences in terms of HIV in the province for gay and bisexual men. So what this graph shows in orange is the number of new HIV diagnoses amongst men who are currently 30 or younger. So we see a steadily increasing number of new HIV diagnoses, whereas we see in older cohorts that the number of new diagnoses is decreasing over time. And the age distribution doesn't change. The average age every year is the same. So this really represents an aging in and an aging out of the HIV epidemic for gay and bisexual men in British Columbia. But it also speaks to the clearly different generational effects. So we know that for younger men, they've never known a world where HIV was not associated with sex, and older men have experienced the height of the HIV mortality pre-heart and are really the survivors of the pre-heart era. And so we have to remember that probably the combination of factors that are important for different generations of men are going to differ, and so we need to think about that when we're thinking about strategies. It's also because the prevalence of HIV is very high. Estimates from Vancouver, for example, have been as high as 20% of gay and bisexual men are HIV positive. In other parts of the province, it's been down to 13%, but it's still very high. And so HIV has clearly got a central role in the community of gay and bisexual men. So for example, in the surveys of gay men in BC, we can see that consistently about 40 to 50% of HIV positive men say that they have a primary partner who's HIV negative, which really speaks to the importance of thinking about serodiscordant couples, as well as the importance of positive prevention and really strategies that need to involve HIV positive men if we're going to be effective. Certainly, testing is obviously one of the fundamental components of Stop HIV, and the rationale for that really is wanting to reduce the people who are undiagnosed and don't know that they have HIV, as well as initiating that progression through to care and treatment and the benefits both individual and at a public health level. Nationally, 20% of HIV-positive men are unaware of their HIV infection. The data from BC does suggest that we're a little bit better than that, at least in Victoria and Vancouver. When we looked at that data from Vancouver, so the Man Count survey in 2008 found that in the total sample, there were 2.5% of men, or 1 in 40 men, who were unaware that they were HIV positive. But when we looked at that in detail, we found that 71% had previously tested, most in the past 2 years. So I know when I first started working in this field and I heard about the statistic of undiagnosed infections, it always conjured up images of people who weren't tested, didn't know that they were at risk. But really, at least in the case of gay and bisexual men, many of these men are already engaged in testing. And so it really speaks to these undiagnosed infections being sort of the crest of the wave of the HIV epidemic as it's passing through the population. We know that gay and bisexual men are well engaged in testing overall in the province. So about 50% of men, no matter what birth cohort, say that they've been tested for HIV in the past year, which is good news. We do see that that varies around the province. This is 2011 data from the Sex Now survey, where we can see that the testing in the past year is highest in the Vancouver area at about 70%, dropping to between 40 and 50% in other parts of the province. So that clearly has an influence on the diagnosis trends that I reviewed earlier. So that's sort of the community relationship, thinking about culture, norms around testing, that kind of thing, sort of as a proximal level. And then finally thinking about the underlying determinants, so the social and structural determinants and the influence that they have on trends. So that's factors looking at the health system, stigma or homophobia, criminalization of HIV non-disclosure, socioeconomic status, housing, racism, and other policy level factors. And again, that's not a comprehensive list. I'm only just going to be showing a few examples that demonstrate that. So we know, for example, that gay and bisexual men and other men who have sex with men continue to experience a lot of marginalization and adversity on the basis of stigma and discrimination related to sexual orientation. So in this survey from the Sex Now survey, we can see very high proportions of men, no matter what age, reporting experiences of verbal harassment, physical violence, forced sex, feeling their career was discriminated against because of their sexual orientation, as well as very high rates of suicidality, which is sort of a marker of the oppression experienced by gay and bisexual men. And we have good evidence to suggest that this data is linked through to unprotected sex and risk for HIV, looking at the same data in BC. But we also know that it's important to think about not just the factors that are associated with increased risk, but also protective factors. So we know that social supports is pretty clearly a positive protective factor that promotes resiliency. When we do look at this amongst gay and bisexual men, the majority of men in all regions say that they have someone that they can turn to to provide social support. And we can see, though, that the proportion reporting poor social support does vary by region, again, with it being lowest in sort of West End and downtown Vancouver, and increasing in other parts of the province. It's really important to think about access or reach and engagement when we're talking about healthcare, and certainly we know there's room for improvement when we're looking at gay and bisexual men in the province. So this is asking men if they have told their primary care provider that they have male sex partners. So that we know that that has implications for HIV testing, as well as obviously other important issues for healthcare, including sexual health in general. And again, we see a fairly consistent gradient in the sense that it's highest in sort of downtown Vancouver, and then lower in other parts of the province. So that's sort of a whirlwind tour and just an illustration of an approach to think about at a regional level or within the populations that you're working with, about thinking about the factors that can influence trends. My take-home messages are really, I think, it's great news that overall there has been a decrease in incidence in BC, particularly amongst injection drug users. However, the rates of diagnoses amongst the heterosexual contacts, exposure group, as well as men who have sex with men are stable. I think it's also important that there's substantial variation, both within these groups or populations as well as within regions, that the provincial data doesn't do justice to. Surveillance data, when you're looking at, just remember that it is heavily influenced by testing, and so that's an important point. And I think with the intent of sort of sharing this framework is also just recognizing that in addition to thinking about these as factors that influence trends, it's also a way to be thinking about what are some of the regional strategies that can be used for prevention as well by acting at these multiple levels. And I will end there.
So we'll make time for one or two questions. If sure, Rekha, come on. There's a mic here just on this pillar.
Up here. All the way over there. Even not loud. That was a great presentation. Thank you very much. I just have one question, which I just need to know whether I'm thinking about this the right way. Just as we're about to feel pleased with ourselves that the diagnosis rate is going down, your data on the new diagnosis rate among men who have sex with men and heterosexual individuals remaining stable. Am I correct in concluding from that unless something changes, the epidemic will look the same among men who have sex with men in 40 years as it does now? And so first of all, I want to know whether that's correct, because I think that will perhaps motivate us to continue to see this as an important problem.
No, that's a great question. And certainly I think that if we do want to continue to make inroads into HIV incidence at the provincial level, we really need to think about how we decrease incidence amongst men who have sex with men, clearly as the population most affected. So I certainly agree with you there. I think that what the data, when we've looked at this recently, really suggests a little bit that we are in a bit of a period of stability, at least in many of these factors. And so I do think that we do need to look seriously at what are some of the other interventions or strategies that we can use that sort of fit within the Stop HIV framework for doing that. And that's in part of the rationale with Perry Kendall looking at this, the Provincial Health Officers Report, and coming up with what might be some ways that we can do that. Because I agree, we do want that outcome. We want to see that dropping. Yeah. Thanks, Rekha.
Sure, Kathy, last question.
Hi, my question's related to ethnicity and testing. And as you're probably aware, in Northern Health around 2007, we had about close to 75% of newly identified positive people identifying as Aboriginal. And so we have seen a decline in that in the last few years. And we're kind of wondering about the percentage of testers completing that question on the form. So is ethnicity being reported, or recorded, I guess, with testing requisitions?
So no, it's a good question, and currently ethnicity is not captured on testing requisitions. And it used to be on testing requisitions, but it was often not completed, and the data quality was so poor. So we have to look at other ways of trying to get at that. So the best proxy that we have, at least in the surveillance data, is looking at it by stage of infection as that sort of proxy in terms of engagement. Also, you have to rely on sometimes local surveys, like iTrack, for example, is one way of looking at HIV testing. I know you've had that in Prince George. But yeah, the lab data doesn't allow us to look at that currently. Yeah.
Thank you very much, Mark.
Great. Thanks, Joe.